All right, good afternoon. Let's see who's joining us today. Um, right now, I don't see somebody had just tried to come into the room, but it disappeared. So let's give it a chance to get going here. All right. Well, let me share the screen, and then whoever joins us can see what I'm seeing as they join us. All right. It does say two participants. Let's see who my participants are. All right. So what we were talking about on Thursday was some pathologies related to the uh, nervous system. So I do want to remind you of some of what those were, and I'm going to show you Alzheimer's again. So Alzheimer's disease is, if you recall, a disease process where um, the brain mass as a whole starts to deteriorate, degenerate, if you will. It often starts with a person becoming disoriented as to person, place, or time, who they are, where they are, when they are. Um, as the condition becomes more advanced, a person will slowly lose the ability to take care of his or herself. Um, that means there's going to be changes to their personality, their intellect, their behavior, their mood, etc. So, lots of symptoms that are consistent with Alzheimer's. You can see this full healthy brain on the right, this uh, degenerating brain. You can see the difference between the sulcus here, and then look at how wide the sulcus becomes, how narrow the gyrus becomes. But eventually, the brain just it's no longer how it was. Um, that means that as this becomes more widespread across the brain, there's going to be a lot of changes to what you notice. And really, there's no test. You don't biopsy the brain to determine if it's Alzheimer's. You base it on signs and symptoms and the nature of how it's progressing. And it's not until after a person's passed away that a coroner can actually make a confirmed diagnosis that it was indeed Alzheimer's. Look at these different stages of Alzheimer's. Memory loss, that's minor. Mood swings, slow reactions, slow to learn new things, in new situations, adapting, handling those situations is uncomfortable. Uh, you know, anything away from familiar is not easy to deal with for that person. Yet, that person can still feed themselves. That person can still communicate with you. That person is, demonstrating the early onset of Alzheimer's. By the time it gets a little bit more advanced, um, this could be an issue where you're starting to see much greater dementia as far as person, place, or time, not knowing where they are, when they are. Um, they may regress back to an earlier stage of their life where those memories are still more intact, and that becomes more of their reality. By the time you get to the third and most severe stage of Alzheimer's, uh, the amount of uh, noticeable symptom to the person, the signs that are evident to others that are observing, it's very obvious that the person is dealing with a severe amount of dementia, very different mood to what is typical for that person, big shift in personality from where that person used to be as a younger individual. So, uh, that person may not be able to recognize their own children, grandchildren, neighbors, spouses. That person eventually loses the ability to feed themselves, clean themselves, eventually lose the ability to do uh, coordinated tasks, can't use uh, techniques to um, manual to manipulate their day. They just can't do it. Their everyday activities become skewed, and even the ability to control bowel or bladder becomes an issue. So they're pretty gone as far as the individual that they used to be. So that's Alzheimer's. And again, with massage, because these people, depending on their stage, because they can become disoriented, you want to do everything in your power to keep the area familiar. If they do become confused, they could be a little bit belligerent. So your safety is of concern also. So make sure that you're in a position where you can easily step back away from the massage table or the chair or whatnot, and until they calm down. And typically I advise, if somebody's got pretty severe dementia with their Alzheimer's, that if they are receiving massage, that there's a caregiver in the room with the client as you're providing massage. So on the science side, these amyloid beta plaques and these neurofibrillary tangles of tau, they become very noticed on slides on biopsy, but you wouldn't know that as a massage therapist. So, and notice that you're typically seeing elderly people. This doesn't usually afflict young people. It can start early on in life, but again, it's mild impairment to more severe. And look, you're looking at about a 15 to 20 year process on the slow side, and a 5 to 10 year process on the fast side of progression, that is. All right, so that's Alzheimer's. Amyotrophic lateral sclerosis was something that we looked at, which is also called in the United States Lou Gehr's disease. They refer to it as DMD over in Australia, which is degenerative motor neuron disease. I do believe the United States will eventually start calling it Stephen Hawking disease, maybe even more European, but I don't know that as fact. Notice that when you look at ALS, this has nothing to do with the sensory side. Here's a healthy neuron to a muscle. Here's an affected neuron and the disconnect from the muscle. So once it's disconnected from the muscle and there's no longer an ability to communicate with the muscle to and from, the muscles start to waste away and the person loses motor control. Notice walking, tripping, weakness, slurred speech, choking, weakness of hands, muscle cramps. Why all these motor things? Why not anything sensory? Because it's only a motor neuron condition, which means they feel everything. They still have their intellect and their intelligence. They're not losing their memories like a person with Alzheimer's. Okay. Notice the way the neuron synapse breaks free from the muscle. Lots of different theories as to what's actually going on. Are the microglia and astrocytes having an effect? Is the synapse problematic? Is there a neurotransmitter issue? Is there here we've got the astrocytes involved in the synapse, and just a number of different potential theories as to what's actually going on. But ultimately, the motor neuron cannot connect either in its circuit to other motor neurons or directly to the muscle fiber, and as a result, again, loss of motor control. Notice that it's affecting just this motor region of the brain, the motor neurons to the muscles. Nothing sensory about it. It's progressive. It leads to more and more atrophy of muscle, more and more disconnect of muscle. A person becomes prisoner to his or her body and eventually relies 24/7 on caregivers to feed them, to clean them, to reposition them, etc. It is something that you can see early on, often around the age of 40 starting. It does affect people more after the age of 60 than it does prior, as far as overall, but look, 40 to 70, and then male, female doesn't really matter. There are some statistics that show slightly higher toward the male side, but mostly it's hard to predict. Most cases are idiopathic, which means the cause is unknown. There are some people that have a familial predisposition because of a type of genetic mutation. There are 3 types of ALS. One of them is referred to as the Marianas Island type. And Marianas Island was over in the Pacific Rim during World War II, a place where neurotoxins were tested, and some soldiers developed ALS following exposure to those neurotoxins. And so that is a 3rd category of ALS. Stephen Hawking was diagnosed when he was 22, I believe, in 1964. No, he was born in 1944. So, or I think he's born in 1944. Either way, he was either 21 or 22 when he was diagnosed, and he lived until 2018. So he lived decades. Most people only, 3 to 6, 3 to 5, 3 to 7 years. And it really, as I mentioned on Thursday, is up to the person when they're ready to give up. So because it's a motor thing, they can't move on their own, but they can feel it all. So they'll feel every bit of your massage. They'll tell you if it's uncomfortable, or at least they'll attempt to try to tell you, because maybe they can't move their jaw or their tongue or their throat to a manner which allows them to speak clearly. So they may have to use other means of communication. All right. Motor neuron disease. Amyotrophic lateral sclerosis. So again, if you massage, just make sure that you are aware that they can feel everything, they just can't respond to it. If you put a little too much pressure, I can move away, I can jerk away, I can actually, change my position, but not the person with ALS. So it's called Lou Gehrig's disease in the United States. A baseball player in the 1930s, very popular, diagnosed, I want to say in 1938. I want to say that's when the speech that he gave in front of Yankee Stadium was. Could have been 39, but I know he passed away in 41. So yeah, it's a sad, debilitating, progressive neurological condition. All right, and there's a picture of Lou Gehrig. All right, so I wanted to talk about Parkinson's disease. Parkinson's disease. So the main thing with Parkinson's disease is that it is another neurological degenerating condition, but this one, the cause is, well, let me rephrase it. The cause of it is still relatively unknown, but the what's going on is certainly observable. And for Parkinson's, it's all about a deficiency of dopamine, the neurotransmitter. All right, so we look at Parkinson's disease. Let's see, let's go to this one. One of the more common things that you see with Parkinson's is something known as a resting tremor. Okay, so when the person's moving, maybe no signs or symptoms of it, but when they're still, whether they're sitting or lying or trying to sleep at night, they'll start to get a pretty prominent resting tremor. The tremor is the result of an inability of the cerebellum to really coordinate the muscle control of the brain. When your brain, the smart part of your brain, the cerebrum, tells a muscle to contract, the signal goes down out of the cerebrum, is picked up by the cerebellum, is fine-tuned, and the muscle contracts with efficiency, conservation of energy, without much difficulty. And a lot of that has to do with the interrelationship of the cerebellum and the cerebrum because of the neurotransmitter dopamine. When dopamine is deficient, the cerebellum can't pick up the communication of the smart brain well enough. So the smart brain is basically telling muscles when to contract and relax. And when the smart brain's saying relax, muscles are struggling to get the proper signal and they start to contract. And then the smart brain's saying, no, relax, because there's feedback coming back to the brain saying it's contracting. And because the cerebellum's not getting involved, it's almost as if the smart part of the brain, the cerebrum, can't keep the muscle in check. So the muscle wants to contract, the brain says relax. The muscle wants to contract, the brain says relax. Muscle wants to, and that is the result of this tremor. The person can feel the tremor, but they don't want it to happen. They've got this active tremor while they're at rest. And again, the more it can be pretty noticeable, just really shaky. And it's almost like, why? What's going on? Why at rest? Well, because when the person becomes active and then they want to do the activity, the amount of dopamine that they do have, it interfaces properly and the cerebellum's able to kick in and movement becomes coordinated somewhat, not constantly. As the condition worsens, the movements do become more and more uncoordinated. That is a true statement. But let me give you an example of what I'm talking about. You may know the actor Michael J. Fox, who played Alex P. Keaton on Family Ties. Okay. Michael J. Fox, the actor, Alex P. Keaton, the character. My fault. Michael J. Fox is from Canada, and he really enjoys not only ice skating, but playing ice hockey. Maybe because he grew up doing it. I don't know. Can't answer that. But he was afflicted with Parkinson's disease 15 years ago, maybe even 20 years ago now. And what was interesting about him was that if he was doing interviews, you could see him kind of restless, moving his head and neck and the resting tremors of his hands. But if he was playing ice hockey, he didn't have any of the tremor, any of the shaking. So there are a lot of doctors that recognize that when a person is involved in an activity that they have some passion for, some enjoyment out of, part of that is the brain using dopamine for that thrill, that thrive of that activity. So their brain's able to use dopamine efficiently. So a lot of treatment approaches now with Parkinson's is to have them, riding a bicycle if they're able, or roller skating if they're able, or singing if they're able, something that they're likely to enjoy, because it allows their brain to use the existing dopamine better. It's a kind of a temporary treatment, if you want to call it that, but it does allow the person a little bit more regularity. But again, as dopamine becomes more and more deficient, then these other issues start to become a problem. They do start to have changes to not only their speech and the way they talk, but changes to the way they write. They do become less likely to enjoy activities. They have a type of gait known as festinating gait, where their feet shuffle until they either fall or crash into something. Their face becomes somewhat expressionless. Their voice changes. They become hunched over, and this is all consistent with Parkinson's. There's an area of the brain. This is what we call the basal ganglia. And it sits below, here's the thalamus, here's the hypothalamus, and it sits below and behind the hypothalamus, okay, as part of the edge, if you will, of the brain stem. And there's an area in there called the zona compacta of the substantia nigra. Substantia nigra literally means the black substance. As long as it's nice and dark, it's dark because of the dopamine that's being produced. Dopamine is able to easily be used by the neurons, again, close to where the cerebellum picks up motor control and even the upward movement of dopamine use by the rest of the smart brain. But when it's diminished, not enough dopamine is used, and as a result of that dopamine deficiency, the signs and symptoms of Parkinson's start to become more regular. Again, he's shaking, he's hunched over, he's relying on a walker because of the fascinating gait. It's more common than ALS, thank goodness, because it's not as progressive. It can be progressive. It's not as progressive, but the person doesn't become a prisoner to their body. They do have issues, and they often pass from usually a heart attack or some other kind of either respiratory or urinary infection, which is common even with ALS and with Alzheimer's, as far as passing away from those things. Heart attacks, urinary infections that become kidney infections, or respiratory infections. Respiratory infections are probably just right behind heart attacks for people with Alzheimer's, and probably just ahead of heart attacks with ALS. So again, here's that midbrain, here's that thalamus, here's that area just on the top of the midbrain that we call the substantia nigra of the zona compacta. All right. So that's your typical person walking with the festinating, which is a shuffling gait, short, tiny shuffling steps. Usually they'll start to lose their balance, and it becomes more and more like, until they'll either hit the wall or hit the ground. Or I remember watching a video of a guy, he was trying to go get his mail, and he just could not stop his gait, and he just fell right in front of the mailbox, but that's your typical Parkinson's. So I showed you a video on Thursday of the pathophysiology of Parkinson's, and in one of the videos, there's a gentleman, if it's still on there anyway, a gentleman that has I want to say he was in California at Cal Berkeley, maybe. Could have been up more Stanford, but my gut tells me he was at Cal. Anyway, they did what's called a deep brain stimulator, a DBS for Parkinson's, DBS, deep brain stimulator for Parkinson's. And when he turns his off, you can see his gait change, his posture changes, his shaking. But this is a different one. This is a shorter one, but this one is basically what the DBS is while it's off and then when it's on. So I'll just let you watch it.
People suffering from ailments like tremors and Parkinson's disease rely on deep brain stimulation as a treatment option. And now researchers are exploring whether this same method can be used to treat everything from depression to disabilities caused by strokes. Deep brain stimulation, or DBS, is designed to use electrical currents to target abnormal brain activity. The method triggers blood flow and a series of chemical reactions that leads to the release of neurotransmitters. Together, these actions help correct malfunctioning connections in the brain. This is how DBS works. A neurologist and other specialists fuse MRI and CT scans of the patient to map out and hone in on the location of the brain that will be targeted. Doctors then surgically implant electrodes on the targeted areas of a patient's brain using a thin probe called a lead. A wire attached to the lead runs through the head, neck, and shoulder under the skin to the chest area, where it attaches to a battery-charged pulse generator that initiates electrical impulses. Then doctors turn on the lead, sending an electrical current to the brain. The patient, now awake, may be asked to move an arm, for example, so doctors can ensure that electrodes are precisely placed. A few weeks after the surgery, the patient visits a neurology specialist who programs how strong of a pulse the device delivers, how long it lasts, and how many times per second the electrical pulses are delivered. Once the DBS device is programmed, it delivers continuous electrical stimulation day in and day out. Doctors tweak the voltage and other settings depending on individual patient profiles and what DBS is used to treat.
All right, yes, for those that have joined us late, we are just going over the rest of the pathologies that we didn't fully discuss on Thursday, and then reviewing the handouts that I gave you, and then summarizing the next few weeks of lecture. That's the game plan for this afternoon. All right, so DBS again is deep brain stimulation used for Parkinson's. There's another version right there. The video that I like to show, if I see it just going down the line here, is this gentleman right here. It says 1 year after DBS. I don't know if you had a chance to watch it, but I want you to watch it anyway, because I want you to watch when he turns off his stimulator, watch the change in his posture and his gait and the shaking of his hand.
Today is the 13th of November, 2010. 1 year ago, on this date, I was in the operating room at Stanford Medical Center for Deep Brain Stimulation Surgery, or DBS. An implanted pulse generator, or IPG, was surgically placed just below my right collarbone and is hardwired under the skin up to the 2 entry points at the top of my head. When it's on, the tremor is optimized. There's virtually no tremor in my right hand. By turning it off with a remote control, you'll see what my condition would be without the DBS. The first 2 attempts to push the correct button failed, but the 3rd attempt worked. The stimulator is now off. Within seconds, you'll see the tremor return. My tremor is a resting tremor, which means when I initiate action with my right hand, the tremor dissipates. When the action stops, the tremor returns. Another visible symptom of Parkinson's is the inability to walk normally. With the stimulator turned off, my body is stiff and I shuffle when I walk. Turning around is difficult and my balance is poor. I don't dare try to hold a cup of hot coffee right now. I don't think you can see it, but close up you'll notice that my face has dropped significantly. I can really feel that at this point. I want to turn the IPG back on now, but I need to put it in my left hand. My right hand would be banging against my chest too much. Within seconds of switching it on, the tremor subsides and virtually disappears. I don't turn the stimulator off very often, but it is definitely an attitude check when I'm feeling frustrated or depressed. Thank God I live in a time with this kind of technology.
So again, he had and that was 2010 when he had his. So assuming that he has another video, it's 3 years after surgery, and I don't know how many more out there, but so there's at least some methods to treat the earlier signs of Parkinson's. But it's just a a dopamine issue. And if we could figure out a way to regenerate that area of the brain, then dopamine would not be a problem and Parkinson's would disappear. Medical treatment is to use a generic medical version of dopamine called levodopa, L-Dopa. The person does become, the term I like to use is hardened to it, if you will. In other words, the effect of the medication becomes less and less effective over time because it's just not the natural dopamine, and the brain isn't able to use the medicine as well as its natural dopamine. So these are Parkinson's. But again, massage, understand that they may have the tremor with massage. So you may have to position them so they're a little bit more comfortable. Sometimes they won't want massage because they don't enjoy the massage with the constant resting tremor. So that's just going to have to be based upon individual client interactions. All right, so that's the story there. All right, let's talk multiple sclerosis. Multiple sclerosis. Simply put, multiple sclerosis is not going to be a one-time event. If it is a one and done, the amount of damage to the brain is usually pretty significant. More often, it's flare-up after flare-up after flare-up after flare-up. Very consistent with any other autoimmune condition. Notice that this picture of multiple sclerosis doesn't look very different than what we saw with ALS. Okay? I don't know why that's the same picture, but the big difference is with multiple sclerosis. I want you to look at the Schwann cells. Look how damaged they are. And the reason why is because the person's nervous system attacks their Schwann cells. It attacks the myelin sheath over and over and over again. And then in the healing, there's often scar tissue. And once it scars, you could even have nerve impulses from one nerve. As scar acts as a bridge between different neurons, the impulse jumps neurons, which completely shorts out other neurons. So there becomes what's called a a motor neural deficit, a sensory neural deficit. The term is deficit. And the reason why is because communication flow becomes disrupted. So let's look at a picture here. Let's try this one to simplify just a bit. An immune-mediated inflammatory demyelinating disease of the central nervous system. What does that mean? That means that it's inflammatory, as a result of a person's own immune system causing the inflammation. Their immune cells attack myelin. Here's an immune cell attacking the body's own myelin, killing its own neurons, causing sensory deficit, causing motor deficit. It just depends on the part of the brain where the attack is. That will dictate what types of signs and symptoms. In other words, if the attack happens to be on the motor side of the brain, there will be motor symptoms and signs. If the attack occurs on the sensory component of the brain, there will be sensory deficit that would be noticeable as signs and symptoms. Motor symptoms are typically felt as weakness or a spasticity, whereas the sensory side, fatigue, paresthesias, which are pins and needles, numbness and tingling, loss of taste, loss of sight, loss of smell, all of these things depending on which part of the brain is being attacked. That's the way a neuron should look. Look at that axon with all those Schwann cells. Okay. Now, it's in the brain and spinal cord, so we should be seeing oligodendrocytes, not Schwann cells. But they are attacked. The myelin sheath is attacked by the immune system. This is what it means to be autoimmune. Those cells think that they're fighting invaders, but they're actually attacking the body's healthy cells, damaging the myelin sheath, damaging the ability of the neuron to transmit impulses. So during that attack, there's what's called a flare-up. And again, it could be motor, could be sensory, just depends on where the attack is. So what happens is when there's imaging done, here's an immune cell attacking the myelin. When an imaging is done, we don't see like a small little area. We see here's one lesion, there's another lesion, there's another lesion, right? 1, 2, 3, 4, 5, 6. I see one lesion there, 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 right? There's these two again, those two again, there's that one again. And we see one of the two there. So it's just getting a little deeper, right? This is what it means, why it's called multiple sclerosis. There's multiple lesions. Attack after attack leaves behind evidence of the assault. And that's what we call a lesion. And it can be on the brain or it could be on the spinal cord. It's a central nervous system attack. It can be on the optic nerve. And again, numbness and tingling, 63.5% of people complain of that. Dizziness, visual problems, pain, bladder dysfunctions, bowel dysfunctions. Look at fatigue. Only after numbness and tingling, second most common. So it all depends again on where in the brain the attack occurs. Lots of signs and symptoms. That's a lot of stuff affecting the brain. So again, if we saw it in video form, we would see the immune cells attacking. Multiple sclerosis. Mayo Clinic's got their version. The National MS Society's got their version. I typically like to show these where we see the assault. So let's take a look.
Reaching your weight loss goals starts with hers, where you can get access to prescription weight loss.
Multiple sclerosis is an immune-mediated disease in which the body's immune system attacks the nerves in the brain and spinal cord. This disrupts the flow of nerve signals throughout the body. Nerve fibers have a protective sheath called myelin, which insulates the nerves, aiding the fast transmission of electrical signals along the nerve fibers. In multiple sclerosis, an unknown trigger causes the immune cells to start attacking and breaking down the myelin sheath. Over time, repeated damage causes hard scar tissue, known as plaques, to form on the nerve. As a result, the nerve impulses are disrupted because the electrical signals can't travel as fast and may leak out between the damaged myelin. Vision, speech, movement, and sensation can all become affected as these functions require effective communication between nerves.
So that was one. Here, a person living with multiple sclerosis. There's a lot of people living with multiple sclerosis. Those videos, certainly there are other explanations. My wife enjoys listening to Ninja Nerd. She says that they're good lectures. They're not bad. Another explanation here, the video I show sometimes that shows the white blood cells entering into the blood-brain barrier. I mean, white blood cells don't really belong in the brain because there's microglial cells, but But in this particular one right here, you can even see in the thumbnail, I'll just go through it. You can see those are white blood cells. And they don't belong in the brain, but they get triggered. They get, here's one telling the other, and then it's like, oh, I got to go out and I got to go attack. And then they come across the myelin sheath from the oligodendrocyte and they attack it. And then they release chemicals that attract others and it damages the neuron. There's an actual attack. This is an attack right there. Look at that. It's just eating away at the neuron and it kills it. And then that activates more and it triggers this flare up. And that is your multiple, your attack after attack after attack. The reason why it's called multiple hardening. Often when there's scar tissue, it's called sclerosis. So scarring, it means hardening, which is, again, the result of scarring. So there are a number of MS videos out there. Here's a white blood cell, here's a medical animation of what's going on. Trying to get that to go further in so you could see it. I'll just let it play a little bit. An introduction to multiple sclerosis. I guess I could have just let it play for real. But I was just trying to get to where it zooms in. That's all I wanted to see. Where it zoomed in, and then one more little look-see at the white blood cells that enter into that area. So if you choose to watch this on your own when you're on YouTube, multiple sclerosis medical animation. Those are white blood cells. We'll get it talking about those in the circulatory system coming up. Those white blood cells they should be in the blood vessels. They should stay in the blood vessels. They shouldn't be affecting neurons at all. But they become misprogrammed. They leave the blood vessel. They extravasate, which means they leave the vessel. And now it's going to be adjacent to a neuron. And for whatever reason in its misprogramming, it'll attack that myelin sheath. And once it starts attacking the myelin sheath, it damages the neuron. Look at those chemicals from the white blood cell that say kill, kill, kill. And there's the dying of your neuron. So that's multiple sclerosis. So who gets it? People who are otherwise also dealing with potentially other autoimmune conditions or family history of autoimmune conditions, including rheumatoid arthritis, not irritable bowel, Crohn's disease, okay, and some thyroid, lupus, those types of things, and those individuals could end up with multiple sclerosis as well. So it is blamed on these autoimmune attacks on the myelin sheath. Here is your classic description of multiple sclerosis. White blood cells attacking the myelin sheath. Attack after attack after attack after attack, causing more and more scar tissue to develop on the brain multiple times. This is MS. I will say it. I don't know if it will be a true statement or if it will be something that will eventually not be true, but in my experience, when people have flare-ups of their autoimmune conditions, including MS, they somewhat hide away from the world, so they're probably not going to come see you for a massage during a flare-up. They may come see you within a few days or weeks or even a few months after a flare-up. It just depends on that person's comfort level and also where their flare-up was affecting them. For example, my wife has a cousin who, when she was in her early 20s, had her first attack, her first flare-up of multiple sclerosis. And she woke up and she couldn't see. It was affecting her optic nerve. She couldn't see. And so, she was very scared. They bring her to the hospital. They made sure they did all kinds of testing, make sure it wasn't a stroke. They then sent her to a neurologist who, through laboratory workup and through imaging, diagnosed her with multiple sclerosis. And over the years, she's in her late 40s now. She was in her early 20s. So she's been dealing with it for the better part of 25 years, roughly. And she's probably had 4 or 5 attacks that we know of. That first one was the most scary, obviously, because she lost her sight. I remember she did have one where she was complaining of numbness and tingling, and her tongue was kind of numb and some loss of taste. So hers was a little bit more sensory for the first 2. I don't remember any motor side attacks that, at least that she told my wife or me about. But maybe it has happened. She is always tired. Fatigue is a main thing, even when there's not a flare-up. So I will say it this way. When there's not a flare-up or an attack, they may have MS, but they are likely to come see you for regular massage. And that's the approach. You want to massage to comfort as you would anybody else that did or did not have MS. If they did happen to come see you while they're actually dealing with a flare-up, I guess just be cautious of what their signs and symptoms are. Otherwise, massage is not typically contraindicated with multiple sclerosis. It is not. So massage away. Just understand that there's a number of different things that the person could complain of, depending on which part of their brain or potentially spinal cord is being affected by this autoimmune assault on their central nervous system. All right. That is multiple sclerosis, MS for short. All right. I want to talk about some brain injuries now. Brain injuries. And probably the most common brain injury as far as impact trauma is what's called concussion. And again, concussion, I'm not going to spontaneously have a concussion just sitting here. Some force is going to impact my skull. My brain is going to end up hitting against the inside of my skull, and there may or may not be contusion, which is bleeding. Concussion. There's been a lot more, if you will, research and effort put toward understanding not just concussion, but concussion in sports, and how to better treat people who have had concussions, and how to minimize the long-term effects of multiple concussions. Do people with concussions complain of headaches? Yes. Does it affect their ability to think? Probably. Could it affect their ability to navigate their day and maybe affect their sleep or their mood? Maybe. Again, it just depends on the severity of the concussion and which part of the brain received the injury. All right, so here is the front of the brain dealing with concussion, but you can certainly fall on the backside of the brain and deal with concussion. There could be temporary loss of taste for anywhere to 3 to 6 months, where taste becomes metallic, loss of smell, visual issues. When there's injury, this is what we call coup, counter coup, which is impact, counter impact. So a double impact, if you will. Headaches, pressure, dazed, nauseous. When I had my more severe concussion, I got nauseous within 20 minutes of my concussion. I had no appetite for the better part of 2 days. I wanted to sleep. I remember that. But yeah, so it could be loss of vision if it's back of the skull. Could be speech issues with the side of the skull. Could be motor impairment if it's the front of the skull. It just depends on where the impact with the brain is. Is it common in soccer? Absolutely. So, head injuries are probably more common in soccer than, well, it's likely that you're going to see ankle and knee injuries in soccer, but head injuries are more common in soccer than they are in sports like baseball or basketball, and that's because of people using their head, and two athletes trying to head the ball at the same time, maybe colliding with each other. So you can see it's an impact trauma. It's a brain injury that temporarily stops the brain's functions, maybe is commonly described as getting your bell rung. There are people that describe seeing stars or butterflies. Okay. It can be fatal. Absolutely, it can be fatal. It is considered a traumatic encephalopathy, which means trauma to the brain itself. Some behavior changes, at least maybe dementia initially, vomiting, absolutely, inability to know where they are, who they are, some memory loss. I think I may have told you about the visual disturbance that I had for the better part of 10, 20 minutes. I don't know how long it was in total. I just remember not being able to see as the people who came to my aid helped me sit up, helped me put my bicycle in their van, went to take me to the emergency room. I remember getting my vision back as we were driving. We were probably about 3 or 4 blocks from where it happened, from my home. It happened, I live close to a tennis court with a parking lot, and that's where I crashed my bike. And I was thrown from the bike hit the back of my head. I was unconscious for, I couldn't tell you how long. Again, the visual, I felt like I was doing this with my eyes not opening, but I'm sure my eyes were wide open, but I couldn't see anything. And I clearly remember, and that was, I was 12 at the time. So let's go back almost 39 years. Okay. But I clearly remember seeing, going, okay, there's the library. All right. And starting to know where I was when I got my vision back. And that's because of the impact. I not only hit the front of my head, but I also had the bicycle land on the back of my head. So this is concussion. So this is one of Nucleus Medical, and I know I had that as part of the links from the handout that I sent you on Thursday. So I'm not going to show you that one, but watch it if you haven't yet, because that's pretty good. I'm going to show you one that's a little bit more. Like this. There's a bruising on the brain. That's called a contusion when it bruises. This is force counterforce. Okay, I'm going to show you this one.
In the lab of Dr. Marta Lipinski, researchers are working to better understand the short and long-term effects of traumatic brain injury. They've learned the initial primary injury triggers cellular and biological changes in the brain that spread to other areas of the brain over time, causing a secondary injury.
After people recover from this initial stage, they can have very profound long-term consequences, and this can involve the immediate disability, cognitive or motor disability. But even people who fully recover have higher predisposition to neurodegenerative diseases decades later.
In a recently published study conducted in mice, Dr. Lipinski showed that traumatic brain injury inhibits an important cellular housecleaning process in the brain called autophagy. After the injury, the recycling function of the brain's immune system cells slowed down dramatically.
This process is actually becoming inhibited and doesn't function. So at a time when the cell really has lots of damaged parts and should be degrading and recycling them, the recycling process is not functioning either and makes the injury worse.
In follow-up research, Dr. Lipinski is collaborating with University of Maryland scientists in the School of Pharmacy, the Institute of Genome Sciences, and at College Park to better understand these long-term effects.
Inhibition of autophagy per se in the neural tissue pretty much causes neurodegeneration. Autophagy is also very important for prevention of neurodegenerative diseases. It's inhibited in Alzheimer's disease and Parkinson's disease and pretty much all other neurodegenerative diseases. So what we're looking at is whether inhibition of autophagy after TBI is the link that causes long-term consequences and causes people to develop neurodegenerative diseases much, much later in life as a consequence.
The ultimate goal of the research is to develop new treatments for the long-term effects of traumatic brain injury.
There isn't really much you can do about the primary injury because it is instantaneous. So prevention would be the key, but we can study and we can try to understand the secondary injury, and we can try develop treatments that can lessen or prevent it.
For the University of Maryland School of Medicine, I'm Larry Roberts. In the lab of Dr. Marta Lipinski.
All right. So autophagy, which is self-eating, is basically something that you see microglial cells do, where when there's damaged parts, it basically cleans it up by ingesting it and then recycling it. And what she's saying is that that whole process is becoming inhibited, and that may be the result of the traumatic brain injury. And as it becomes inhibited to where that self-cleaning system of eating up the debris disappears, well, then that person's going to be more and more likely to develop, Alzheimer's or some other Parkinson's neurodegenerative issues later on in life. So lots and lots of video on traumatic brain injuries, and a lot more emphasis in understanding the long-term effects, short-term effects. Again, a lot of organizations relative to athletics, schools, now they make coaches and PE teachers take extra classes on recognizing the signs and symptoms of concussion and then removing the athlete from the event or removing the student from the activity until they can go through a protocol to determine if there is indeed enough traumatic brain injury that requires medical attention. So that is a concussion. If a person's had a recent concussion and is coming in for massage and there's any confusion, disorientation, anything like that, encourage them to be taken to an urgent care facility or an emergency room and let that be evaluated by medical staff. All right. If a person were to fall down and strike their head, for example, falling off the massage table, be aware that concussion may be the result. And again, hopefully nobody ever falls off your table, but let's be cautious of potential brain traumas. It's called concussion. Another brain trauma is referred to as cerebrovascular accident, also known as stroke. It may not be impact trauma, but it is still considered traumatic to the brain because of the loss of blood supply. And there are two types of stroke, what is called an ischemic stroke, and there's the word, and what's called a hemorrhagic stroke. Ischemic stroke is when you cut off the blood supply, usually because of a blood clot or some other kind of embolus, and you can see it in this one where it traveled, ischemic and hemorrhagic. So this is going to show you both types. All right, let me play it.
We will learn all the relevant medical information about stroke or cerebrovascular accident in this video. A stroke occurs when the blood supply to a portion of the brain is interrupted. It is a serious, perhaps fatal medical illness. A stroke is a medical emergency that requires prompt attention. The likelihood of permanent damage is decreased the faster a person receives treatment for a stroke. Cerebrovascular strokes come in two types: ischemic strokes, which are brought on by blood vessel obstruction, and hemorrhagic strokes, which are brought on by blood vessel rupture. Both kinds of strokes deprive a portion of the brain of blood and oxygen, which results in the death of brain cells. The most frequent type of stroke, known as an ischemic stroke, is brought on when a blood clot obstructs a blood vessel, preventing blood and oxygen from reaching a portion of the brain. One of two things can lead to this. A blood clot that originates elsewhere in your body and lodges in a blood vessel in your brain is one way to have an embolic stroke. A thrombotic stroke, on the other hand, happens when a blood clot develops in a brain blood vessel. A hemorrhagic stroke happens when a blood vessel bursts, or hemorrhages, and blocks the flow of blood to a portion of the brain. Any blood artery in the brain or the membrane covering the brain may have a hemorrhage. Another related illness known as a transient ischemic attack causes a brief interruption in the blood supply to the brain. A mini stroke results from this, which might last a few minutes or last up to 24 hours. A transient ischemic attack is frequently an indicator that you are soon to experience a complete stroke. The main risk factors for cerebrovascular stroke are high blood pressure, diabetes mellitus, high cholesterol, atherosclerosis, smoking, drinking, coagulation problems, and irregular heartbeats. What signs or symptoms point to a cerebrovascular accident or stroke? Depending on where in the brain the stroke has occurred, the symptoms of a cerebrovascular accident can change. Symptoms typically start off mild and unexpectedly, but might worsen with time. The more quickly you can be diagnosed with a stroke and begin receiving treatment, the better. It is crucial to comprehend and identify the signs of a stroke because of this. Stroke symptoms include difficulty speaking or walking, numbness or paralysis in the face, arms or legs, usually on only one side of the body, impaired vision, and a sudden headache. The word FAST can be used to recall the primary stroke symptoms. If you see any of these symptoms, dial 999 right away. The letters F, A, S, and T stand for face, arms, speech, and time manifestations, respectively. How is a cerebrovascular stroke diagnosed? Once you check into the hospital, things will move rapidly. The hospital emergency staff tries to identify the sort of stroke you are experiencing. Blood tests could be necessary to evaluate your blood's ability to clot quickly, your blood sugar levels, whether you have an infection, and whether you have dyslipidemia. A computerized tomography, or CT scan, can detect brain tumors, ischemic strokes, bleeding in the brain, and other diseases. In a procedure known as computerized tomography angiography, doctors may inject a dye into your bloodstream to view the blood vessels in your neck and brain in better detail. A more precise image of the brain is produced using magnetic resonance imaging, or MRI. An MRI can identify brain hemorrhage and ischemic stroke damage to the brain tissue. How to manage a cerebrovascular stroke? Whether you are having an ischemic stroke or a hemorrhagic stroke will determine whether you need emergency treatment. Doctors need to swiftly reintroduce blood flow to the brain in order to treat an ischemic stroke. Emergency endovascular procedures or IV medicines may be used for this. A clot-busting medication must be administered within 4.5 hours of the onset of symptoms. The sooner these medications are administered, the better. Through the intravenous administration of this medication, which is known as thrombolysis, blood flow is restored. It is crucial to perform a brain scan to confirm the diagnosis of an ischemic stroke before beginning thrombolysis. This is due to the possibility that the medication could worsen hemorrhagic stroke-related bleeding. Doctors can use a device connected to a catheter to directly remove the blood clot from the blocked blood vessel in the brain, if the patient arrives after the first 4.5 hours, or if the blood clot is huge and cannot be entirely broken up with medication. The only big blood vessels in the brain can be used for this thrombectomy procedure. The primary goals of emergency hemorrhagic stroke care are to stop the bleeding and ease the pressure that the extra fluid is putting on the brain. Both medicine and surgery are options for achieving this. What about stroke recovery and rehabilitation? After receiving emergency care, you will be closely watched for at least a day. Following that, stroke care is geared at assisting you in regaining as much function and your ability to live independently. The area of the brain affected by the stroke and the degree of tissue damage determine the stroke's effects. Your movement and sensation on your left side of the body may be compromised if the right side of your brain was impacted by the stroke. Your right side mobility and sensation may be compromised if the stroke damaged the brain tissue on the left side of the brain. Speech and language problems could result from left-side brain injury. Based on factors such as your age, general health, and the extent of your stroke disability, your doctor will propose the most demanding rehabilitation program you can handle. You might start your rehabilitation before you leave the hospital. You could carry on with your program in any hospital's rehabilitation facility after being released.
Interesting that that video is put together by somebody with an Indian name, with Americanized artificial intelligence narration, but over in England. And they can tell because they said dial 999, which is England's version of 911. But yeah, it's an emergency situation. So if anybody were to have just sudden symptoms of disorientation, confusion, numbness in their face, or, usually in their face, or, you know, instantaneous headache, something like that, and they just don't look right, or they're not communicating properly, don't assume it's adverse effects of medication. Don't assume that it's just a personality flaw. They could be having a stroke. They could have had some kind of ischemic event where blood clot dislodged, and now the embolus traveled and blocked part of the brain, and it starts to die. Or perhaps a small aneurysm burst, or a weakened blood vessel burst. And the truth is, anybody, any age, any time could have a stroke. I've had students, one student was 16 when he had a stroke. It actually happened in the emergency room. He came home from school with a really bad headache. The headache didn't get better. Mom took him to the emergency room, and while in the ER, had the event where the blood vessel burst, and he had a type of hemorrhagic stroke. Former student whose son at 18, after graduating high school, was living at home still, was going to be going away to college. He and his girlfriend had intercourse, and upon completing intercourse, he had a hemorrhagic stroke from a weakened blood vessel they didn't know he had, and 3 days later he died from it. I told you on Thursday about a patient, or maybe I told you in lecture earlier about a patient who was driving down Interstate 64. They were headed to St. Louis from the Illinois side when he had a stroke, and even though it was mild and they were able to get to the emergency room later on, that I think he went the next morning to the emergency room, but he still ended up with right-sided contractures to his elbow, his wrist, and his ankle as a result of the injury to the left side of his brain with the stroke. So, and his was a blood clot that was in a heart valve that broke free and got stuck in a vessel. So it was an ischemic event. If a person's had a history of stroke, you can massage them. If they do have contractures, which are permanent states of contraction, don't try to force the joint beyond what it can do. Just go to the tolerance and mobility of the joint, and you'll find that muscles are real rigid and ropey. Just work to them through to tolerance, excuse me. So, again, here's an example of a blood vessel that's demonstrating a clumping of blood cells. That's going to be an ischemic stroke. Hemorrhagic is more of a burst in a vessel where it tears and bleeds. So lots of videos on stroke. It is an emergency situation if it happens in real time. So they should be 911 brought to the hospital so that they can minimize the damage to their brain. All right. The final injury to the brain, anyway, that I want to talk about happens while in the womb, during the delivery process, or within the first few months of life. And it's an injury to the brain called cerebral palsy. Brain injury to the developing brain. And again, all kinds of signs and symptoms of this condition, because it's all based upon where the brain damage occurs. It can happen in so many different places of the brain. The motor side causes spasticity. The sensory side causes a lot of neurosensory deficit. Cerebellar palsy would cause ataxia, which is a clumsiness of sort. Again, here we have just one limb affected by part of the brain, whole half of the body by a more significant half of the brain. That's called hemiplegia. The whole lower half, a type of diplegia, or all four limbs affected, a type of quadriplegia, all because of cerebral palsy. Not a spinal cord trauma of true quadriplegia or paraplegia, but of brain injury to the developing brain. You can see the spasticity of contractures in both arms in this child. You can see the lack of development of teeth, of muscles. Here, severe cerebral palsy causing them to be wheelchair bound, requiring a walker, right? Injury to their developing cerebrum in the womb because of blood supply getting cut off, like the umbilical cord being wrapped around the neck. It can happen because of trauma to the head, either during labor, during delivery, after they've been born, car accidents, falls, dropped. So many types. And look at all this, all because of the injury to his cerebrum. Now relying on that device to help him learn to walk as best he can. This is cerebral palsy. And here you have, he grew up with it, right? Look at the spasticity of his wrists, of those flexor muscles of his wrists and fingers. Those muscles atrophy, they contracture. He probably drools. He probably, can't talk well. He's reliant on, help for moving joints best that they can move. And he's had the better part of his life because of the injury to his brain, the developing brain. Cerebrum is the big part of the brain, and palsy is the paralytic trauma. Paralytic trauma. And again, there's so many types depending on how much of the brain's involved. There are people that have had such mild forms of cerebral palsy that you would otherwise not know that they had any brain injury at all. Some that maybe there's some asymmetries between the sides of their body, if it's that hemiplegic type. And then, of course, the more severe types of cerebral palsy aren't conducive to very long life. You can see that his cerebral palsy affecting his lower limbs is different than his cerebral palsy, where that person has the ability to use a walker, very different from that child's cerebral palsy that affects all four limbs, probably has a lot of stunting of mental as well as intellectual development of the brain. So many different types of cerebral palsy. Can you massage these people? Sure. Should you be aware of any contractures or things of that sort? Absolutely. But it's when I was going through school, I used to travel when I was going through chiropractic school anyway, to Union, Missouri once a week to work at the Rainbow Activity Center, where a lot of the patients of this facility, it's a place where people are brought during the course of the day for rehabilitation. We would provide chiropractic and massage for these individuals, and many of them had cerebral palsy, and they loved the care that they were getting. But it's to help improve the quality of life, but it's not going to cure the condition. The injury happened so long ago to their developing brain, and the rest of their brain grows around it, and they some parts of the brain pick up the responsibility of other parts of the brain, and whether or not it will be as debilitating as you see with some of these pictures, or whether it'll be very mild, again, just depends on how much injury there truly was to that developing brain. All right. That is cerebral palsy. Please don't get that mixed up with Bell's palsy. All right. So far we looked at Alzheimer's, ALS, Parkinson's, multiple sclerosis, concussion, stroke, cerebral palsy. I want to look at 2 spinal cord traumas and then Bell's palsy. The spinal cord traumas first are based upon where the spinal cord is injured. All right, so I'm going to show you spinal cord trauma. Spinal cord injuries are the result of motor vehicle accidents, diving accidents into pools that are too shallow, and occasionally you see them in impact sports. But motor vehicle accidents are probably top of the list as far as spinal cord injuries. You could injure the cervical portion of the spinal cord, the thoracic portion of the spinal cord, the lumbar portion of the spinal cord. Technically, you cannot truly injure the sacral portion of the spinal cord. If you were to injure the sacral area, anywhere below L2, it would be known not as a spinal cord trauma, but cauda equina trauma, right? The horse's tail. The horse's tail. So not truly the spinal cord, because it ends between L1 and L2. So there are two types of paralysis that are resultant of spinal cord trauma. They're referred to as paraplegia and quadriplegia. The person who's paraplegia has full use of his or her arms. The injury to the spinal cord was below the brachial plexus. Now, injury can be to where there's just a partial injury to the spinal cord or a complete, what's called transection, a complete slice through the spinal cord. If it's an incomplete injury, it is possible that the amount of paralysis is minimalized. If it is complete hemisection or transection of the spinal cord, then there's going to be a much greater bilateral effect and most likely something that's not repairable that they're going to deal with the rest of their life. The spinal cord can be compressed, it can be torn, it can be broken, it can be kinked, and not, I mean, there's so many potential threats. And hopefully the spinal column itself prevents that. But usually the forces that go through that cause fracturing of the vertebrae, and that force then damages the spinal cord as well. This is a crushing effect of a vertebral body, and the force that caused that can also cause severe damage to the spinal cord. Severe damage to the spinal cord. If the injury is above C3, the spinal cord is injured above C3, that person cannot breathe on their own. That person will lose all use of their arms and their legs and will rely on a ventilator or something else to breathe for them. Because you must have at least C3, 4, or 5 intact for the phrenic nerve, which is your diaphragmatic nerve that allows you to breathe on your own. So the person with an injury above the brachial plexus, like in this picture here, there's C4, there's C5, there's C6, right? Or C4 and C6. Notice that the arms, the body, and the legs are all affected. Some of the shoulders a little bit more involved, but if it's like C7 or C8, they'll have a little bit more out of their arm. But if any paralysis whatsoever of the limbs, it's still considered quadriplegia. Any paralysis to the upper limbs. If it's only the lower limbs, like we see here at T6, or this is a cauda equina syndrome, L6, I've never even heard of L6. L5, S1 area, then it's just going to affect below the waist. So here you've got an entire quadriplegia, or also known as tetraplegia. All 4 limbs can't even move their shoulders. A little lower, a little bit, and they have sensation. Wherever it's not blue, they have sensation and motor control. So it's getting lower and lower, and more of the body is being, the communication flow is still there. There. That is an example of the spinal cord being hemisectioned. Complete injury. That person is going to, so here's C2, C3, C4, C5. This happened at C6. This person is going to have quadriplegia. Now, they will have some sensation out of part of their arm. They will have some ability to move their elbows, but this person's going to lose grip. They still have all 4 limbs affected. That's quadriplegia. See it? How the fracturing of the bone also damaged the spinal cord. Let's just pretend for a moment that this is T4. Just pretend it's T4. Everything above T4 is going to work. Motor control and sensory back and forth to the brain, but everything below is going to be absent. That person's going to be paraplegic. paraplegic. Here you've got, there's the end of the spinal cord right there, okay, where the hand is. Here is the fracture with the damage to some of the horse's tail from actually, this is a disc bulge. And so that's going to have a little bit of cauda equina syndrome, but not spinal cord trauma. So again, this is quadriplegia, an injury above the brachial plexus or the brachial plexus. If it's below the brachial plexus, okay, and I don't know why they're showing it here, okay, if you're injured right here where the hand is, you're going to have full use of your arms. Well, absolutely 100% full use of your arms. As long as it's below the brachial plexus, it's only paraplegia. Oh, that's a bad one. Okay. Look at how the fracturing of the vertebra snapped the spinal cord between T4 and 5. So everything above T4 is going to stay intact. They'll have full use of their arms, but that person is now paraplegic for the rest of their life. Paraplegic. Loss of, and again, here, paraplegic. This one's more quadriplegic. Look at that extreme hyperflexion injury. That's if they even survive it. They may not survive that trauma. Okay. This is technically, if the hands are involved, they need to gray out the black of the hands needs to still be there. Okay. If it's just below the waist, paraplegia, but they'll have full use of the arms. Here you can see full use of the arms, paraplegic. But any paralysis whatsoever to the limbs, all four, quad means 4. So quadriplegia. All right. So what does that mean for massage? Well, let me ask you this. If a person can't feel their legs and you're massaging, can they give you appropriate feedback? Can they tell you it hurts? Can they tell you it's too much pressure? They cannot. Doesn't mean they won't get some positive effect from having their legs worked. They just can't feel it and give you feedback. So you may need to use more Swedish type approaches, lesser deep tissue. The areas that they can feel and move, they'll be able to give you feedback no different than any other. So some people massage paraplegics similar to massaging people that are amputees. They'll do real light work around the area of the amputation. They'll do real light work around the area that's paralyzed. And then they'll do a regular deeper tissue, whatever type massage above the area of the spinal cord trauma. When a person's quadriplegic, let's say they're quadriplegic and relying, and they have to use a motorized wheelchair, for example, to move around, quadriplegia. Well, they're not even going to be able to move their arms. They're not going to be able to give you any feedback, right? Okay. Now, again, if it's partial, like, for example, you can see the difference. This is your paraplegic, paralyzed from the waist down because of spinal cord trauma that would have happened right about here. Quadriplegic because of spinal cord trauma that happened in the neck. That person you're going to have to be a little bit more cautious with. They're going to feel good working the neck and the upper shoulders, but they can't give you feedback everywhere else. It's a complete disconnect. That is quadriplegia versus paraplegia. The person that's got hemiplegia had a brain injury, a stroke, cerebral palsy. Hemiplegia cannot be the result of the spinal cord. Only quadriplegia or paraplegia. Again, all 4 limbs affected with quadriplegia. Be cautious in massage everywhere. Paraplegic above the area of trauma, massage away. Everything's regular as if anybody else. Below the area, be more cautious as far as depth and pressure. All right, that is quadriplegia versus paraplegia. Again, those are spinal cord traumas. The person that's got this hemiplegia where half of their body's paralyzed, again, that's the brain. Stroke, cerebral palsy, something of the like. All right. So again, the Olympics will be coming on in a few weeks. And when that's done, there will be the Paralympics. And there'll be many events where you'll see people who are paraplegic competing, where they've got full use of the upper body, but the lower body has been affected by the trauma or whatever it was. This person right here is paraplegic. That person's quadriplegic. So at current medical technology, we just don't have the ability to repair that damage. All right. Lastly is Bell's palsy, which sounds like it should be a paralysis also, right? But Bell's palsy is a type of paralysis due to an irritation of a nerve. And that nerve specifically is cranial nerve 7, the facial nerve. Now, I want you to take a look at this individual, and I want you to look. Let me open this as its own tab so we can zoom in on it. I want you to look at his face. You see how there's wrinkling over here on this side of his scalp? His eyebrows going up, his lips will go up, his nostrils raised, there's wrinkling of the eyes, right? This is the good side, his left side. Notice the drooping of the lips, the dropping of the eyebrow, the almost wrinkle-free forehead. That is the Bell's side. This person cannot close his eyes. He cannot raise his lips. He cannot flare his nostrils, he cannot wrinkle his forehead. He cannot move the right side of his face. Why? Because something has caused irritation to his facial nerve, and it is cutting off the information flow between the brain and the muscles of facial expression on that side of the face. Now, I'm going to go through a bunch of pictures, and I'm just going to ask you with, let's do Bell's palsy face. Okay. And I want to do images. I just want to see their faces, like this guy. All right, let's go through these faces. All right, so when you look at him, there's the wrinkling, there's the raising of the brow. This is the side of his face that is dealing with Bell's palsy. Okay, here's the facial nerve going to muscles of facial expression. Bell's palsy is when it affects the cranial nerve 7. Here is the drooping side, that is her Bell's side. The nerve on each side of the face that's responsible for muscles of facial expression becomes compromised, usually in the area around the ear, inside the ear, like ear infections can do it. Again, the drooping. So this is the Bell side on him, his left side, her left side. Her right side, you can see the wrinkling of her left side. Notice that her eyelids are going up, opened wide. She can actually open her eyes because the eyelid here, the muscle that opens the eyelid is actually cranial nerve 3, but every other muscle of facial expression on that side of her face is cranial nerve 7. Look, she's trying to go like this. See my face? Only her left side's doing it. Her right side is staying still. And now look, she's smiling. She's getting some of it back. There's still a little bit of evidence in the fact that her eyebrow's not raising, that her lips aren't fully forming. Look at the difference in her left cheek to her right cheek. But that's how bad it was, and it's getting better. She can move all of her. She can go, all right, make all of it. She's trying to smile. She's trying to do, but half of her face is paralyzed. That's Bell's palsy. Here she is dealing with Bell's palsy on her right side. A little later on, you can still see some of the evidence on her right side. There's the wrinkling, there's the opposite, there's the drooping. I like to say it's better than Botox wrinkle-free, the side of the Bell's palsy. Look, she can close her left eye, she can't close her right eye. The Bell's palsy's on her right. He can raise his right eyebrow, he can raise his lips, the Bell's is on his left. See how he's trying to close his eyes? The eye closes on the left, the mouth closes, but it droops on the right. The eye doesn't close on the right. That is the Bell side. Yeah, they tape their eyes shut. Look, she's trying to go like this, which her right side does, but her left side just won't do it. The parotid gland getting irritated can cause it, but it will only cause partial. If it happens deep in the ear, it's going to hold the whole of the face. Okay. Cranial nerve 7 palsy, facial nerve palsy, Bell's palsy. Can massage be effective in helping it to speed up its recovery? Sometimes. It really just depends on what's causing it. The most common reason is a viral inflammation followed by ear infections. The virus is usually herpes simplex, but it can be herpes zoster. Okay, starting to get some of it back. This left side of her face is moving, the right side of her face, not so much. There's the droop and the open eye and the drop of the eyelid. Here is the wrinkling of the raising of the brow. She is not able to get that wrinkling. Okay, a little before and after, where he lost his left side and he's starting to get it back. And it's usually temporary, but there are some times where it becomes more permanent. Tumors, strokes. Yeah, you could have a stroke affecting the nerve in some way, shape, or form, and then it's a permanent thing. But it's usually a virus, usually temporary. Like there's Angelina Jolie, she had it. Look at her trying to smile, and she just can't get it. And there she's getting her smile back. And the truth is most people still, even after they've recovered, still have a little bit of evidence of their Bell's palsy. Look at the wrinkles on the right side of her forehead, but not the left. That is Bell's palsy. There may be a little bit of their tongue numb or loss of taste, but for the most part, it is affecting their ability to move their face. The reason why the tongue feels tingly sometimes is sometimes people have Bell's palsy. It also affects the trigeminal nerve. So they have a type of what's called neuralgia of the trigeminal nerve, and then it'll cause patches of numb spots. But more likely, there'll be a lesser amount of taste from that side of the tongue, because again, the front 2/3 of the tongue, the same facial nerve, the sensory side of it being affected. So that is Bell's palsy. I say massage away. All right, so those are the 10 pathologies that I want you to know. What I'd like to do now is go over the 2 quizzes that I sent along on Thursday. I sent a cranial nerve quiz and I sent a spinal nerve quiz. So I'd like to open them up so that we can match them up. I'll do the cranial nerve one first. I couldn't find the Body Therapy Center one, so I sent you one from my other school. It's the same cranial nerve quiz information. I mean, that stuff doesn't change much. And let's go ahead and answer these. And I also sent you a study guide. And I tell you what, let's answer the study guide questions first, and then these quiz questions. So let's do that study guide. The study guide. All right, so hopefully you had no problem printing up the study guide or you used it in some way, shape, or form. But what we're going to do right now is answer those. If you were able to answer these easily, you'll be able to, on the test, answer many, many questions. And if you had some difficulty, I want you to either rewatch some lectures or read in the book, the Nervous System, Chapter 23 in the Salvo book. And that way you can find these answers. All right, so what constitutes the central nervous system? You should have the brain and the spinal cord. Anything that's brain or brain part, including the meninges and the cerebral spinal fluid. Anything that is spinal cord, including its meninges and cerebral spinal fluid, all constitute the central nervous system. So what makes up the peripheral nervous system? To answer that question, anything that's nerve, that's not brain or spinal cord, like the cranial nerves, the peripheral nerves, whether the peripheral nerves are the somatic division, go into voluntary muscles and joints, whether it's the autonomic division of fight or flight or rest and digest. If it's not brain and spinal cord, it is peripheral nervous system. All right, so hopefully those two are easy to answer. The neuron. What are the receiving branches of the neuron called? The neuron has receiving branches, inlet branches called dendrites, which means little trees, full of branches and spines of the little trees. What is the large central portion of the neuron called? The large part of the neuron is its cell body, sometimes called the soma of this neuron, the cell body or soma. And it has a large nucleus. It's got all your regular organelles, including endoplasmic reticulum, Nissl bodies, microtubules. It's full of cell parts. And that central nucleus is often very, very large because there are a lot of proteins involved in neurons. So the large central portion of the neuron is its cell body. What is that long tail called? It is the axon. The axon. And there's a fatty sheath that surrounds the axon, and it is called the myelin sheath. The myelin sheath, which we'll see that in the central nervous system are made by one type of cell, but in the peripheral nervous system, the myelin sheath is made by a different cell type. And what are the ends of the neuron called? Well, the ends are called, fancily, telodendria, or terminal bulbs, terminal ends, synaptic bulbs. I prefer terminal branches and terminal bulbs because terminal means the end. But you could say telodendria if you really wanted to. You will have to label a neuron on the test. Neuroglia, the nerve glue. What are the 4 types of neuroglial cells in the central nervous system? They are the star cells called the astrocytes that feed the neurons. They are the oligodendroglia, the oligodendrocytes, which myelinate the neurons. There are the microglial cells that protect the neurons. And there are the ependymal cells, which line the ventricles so that cerebrospinal fluid can be utilized by neurons. So another way of feeding the neurons, if you will, and protecting the neurons. So that is the neuroglia of the central nervous system. Astrocytes, which means star cells. Oligodendrocytes or oligodendroglia, which means few branch cells. Microglia, which means small blue cells. And ependyma or ependymocytes, ependymal cells. Ependymal, some people say, which are lining cells of the ventricles. The ependyma being the, we said that it meant the outer shroud, the outer sheath. What are the 2 types of neuroglia of the peripheral nervous system, the PNS? The Schwann cells that myelinate the axons of neurons, and the satellite cells that essentially allow for ion and gas exchange between neuron cell bodies and the blood. So another way of feeding the neurons of the periphery. Schwann cells and satellite cells. And those are the 6 neuroglia. Impulse conduction. What are the 2 terms that describe nerve impulse directionally toward the brain? Well, the simpler term is sensory, and the more complex word is afferent. Sensory or afferent describes nerve impulse directionally traveling towards the brain. And if they are traveling as nerve impulses directionally away from the brain, those are either called motor impulses or efferent. Motor impulses or efferent, going to the muscles, the joints, the skin. As long as it's motor, it's efferent. The impulse is traveling away from the brain to the body. As long as it's sensory afferent, it is traveling toward the brain for interpretation. What is the largest part of the brain called? The big part of the brain is called the cerebrum. The cerebrum. It is summarized as your smart brain, your cognitive, intellectual brain. What are some of the functions of this? Well, it's receiving all that sensory information from your body to process and analyze it. So it interprets sensation. It allows you to be aware of your environment. It is responsible for making decisions about the information coming into the environment. So there's cognition, which is awareness of surroundings. There's intellect, which is decision making. There is planning and execution of movement on the motor side of the brain, personality, mood, behavior, speech. So if I see it, hear it, smell it, taste it, that's the sensory side. But if I move it, it's the motor side. All that coming from the smart cerebrum. What area of the brain is most responsible for balance against gravity so you don't fall down and has fine motor control? The cerebellum. The cerebellum. And which part of the brain associates with vital life processes? And what are the 3 divisions? Well, if it's vital life processes, that's brainstem. And the three divisions from highest to lowest are midbrain, pons, and medulla oblongata. Midbrain, pons, and medulla oblongata. What are the two portions of the diencephalon and what are their functions? Well, the diencephalon is capped on top of the brainstem, and you've got 80% of it, which is thalamus, and 20%, which is hypothalamus. The thalamus is the sensory relay. All sensations from the body go through the thalamus, and it knows where in the smart brain to send it. So it's a sensory relay. And the absolute only sensation that does not go through the thalamus, that goes directly into the smart brain, is the sense of olfaction, which is the sense of smell. The sense of smell. Every other sensation, whether it's vision, touch, proprioception, which is positional awareness, nociception, which is pain awareness. If you can feel it, it's going through the thalamus. If you know where your body parts are, it's going through the thalamus. If you feel nociception, noxious, pain signaling, it is going through the thalamus to know, because the thalamus knows where in the smart brain to send it and with what priority. But the hypothalamus, that's all about monitoring homeostasis. Monitoring homeostasis. All right, the spinal cord. Where does the spinal cord begin? At the foramen magnum of the occiput, the big hole in the occiput. Where does it end? It ends at the level of L1, somewhere between L1 and L2. The level of L1. Sometimes you see it ending L2, sometimes you see it somewhere between L1 and L2. It comes to an end. How many segments make up the spinal cord? 31 segments make up the spinal cord. And how are they defined? By where the paraspinal nerves connects to the spinal cord. One pair of spinal nerves, that's a segment. Next pair of spinal nerves, that's a segment. Next pair of spinal nerves, that's a segment. How many are cervical segments? 8. How many are thoracic? 12. How many are lumbar? 5. How many are sacral? 5. How many are coccygeal? 1 segment is coccygeal. A total of 31 when you add all those up. 8, 12, 5, 5, 1. What is the combination, or sorry, the continuation of nerve bundle extending beyond the end of the spinal cord called? Well, once the spinal cord comes to an end, what still remains in the canal is the horse's tail, known as cauda equina. Again, cauda means tail, caudal is tail, equine is horse. The tail of the horse, cauda equina. And what is the general function of the spinal cord? It is the central highway of information, the huge relay between body and brain and body. The cranial nerves. Knowing cranial nerves is simple when you know what the words that are naming the cranial nerves mean. So what I have you do for the purpose of the study guide is using the word bank out to the right, matching up what these things mean. Olfaction, optic, oculomotor, trochlear, trigeminal, abduction, expression, auditory, glossus, pharyngeal, vagrant, and accessory. Why? Because if you know what all these things mean, you can then translate your 12 cranial nerves, and that tells you their general function. Olfaction is smell. Optic is sight. Oculomotor, eyeball mover, eye mover. Trochlea, pulley, and then it has to do with the fact that a muscle goes through a pulley, one muscle, to roll the top of the eyeball up and into the trochlea, the pulley, which makes you look down and in. It rolls the eyeball up and in, but when the eyeball rolls up and in, you look down and in. All right, so that's the pulley. Trigeminal means triplet. 3 branches. Abduction is taking away, and if your eyeball is taken away from the midline, you will look laterally. Expression, nonverbal facial movements is expression. Auditory is hearing. Glossus is tongue. Pharyngeal is throat. Pharynx, throat. Vagrant is wandering all over. Wandering around all over. And accessory means aiding or assisting. So when we name our cranial nerves by using these translations, we should be able to easily match up what they do. Easily. All right. The spinal nerves. How are spinal nerves numbered? Where they exit the vertebral column. I don't care if they exit at C1, above C1. I don't care if they exit below C7. I don't care if they exit below L4, L5, or even come out of the sacrum. Where the nerve pairs exit, that's where we number that spinal nerve, and even that segment of the spinal cord where the spinal nerves connect to the spinal cord, where they exit the vertebrae. What is the nerve grouping of the upper neck called? Well, when it comes out of the upper grouping and interconnects, it's called the cervical plexus, which is the grouping of nerves that root out of the vertebral column between C1 and C5. What is the nerve grouping of the lower neck that's from C5 to T1, C5, C6, C7, C8, and T1? Those are the nerve grouping called the brachial plexus. As far as the lower back, all the way from T12 down to S4, those are the lumbosacral plexuses. The lumbar plexus and sacral plexus combined into one big lumbosacral plexus. And what is the most important nerve of your upper limb? Of the upper limb, it's got to be the median nerve for grip. That's why grip, flexion of the thumb side flexors. Median nerve, grip. What is the most important nerve of the lower limb? The femoral nerve. Why? Because it innervates the quadriceps, and there's no walking if the quadriceps don't work. I don't care how powerful the gluteus muscle is for the hip. I don't care how powerful soleus is for the ankle. If you cannot keep your knee from buckling, which is what quadriceps do, you're not walking. And the median nerve for the grip is important for the upper limb, but the quadriceps nerve is the femoral nerve. What is the body's largest nerve? Sciatic nerve. Not as important as the femoral nerve, but bigger. And it's bigger because it's really the nerves of the leg combined before they branch and become the leg nerves. What muscle group does the sciatic nerve innervate? The hamstrings, which are not nearly as important to you as walking as your quadriceps are. The sciatic nerve innervates the hamstrings, which are biceps femoris, semitendinosus, and semimembranosus, whereas the quadriceps are rectus femoris, vastus medialis, vastus intermedius, and vastus lateralis. Rectus femoris and the vastus brothers, important nerve, femoral nerve. Biceps femoris and the semisisters, not so important. Sciatic nerve, not so important to that. Okay? The autonomic nervous system. Which part of the ANS is called fight or flight? Sympathetic. It even has a chain of ganglia of cluster cell bodies, sympathetic. The part of the autonomic nervous system that has a chain of ganglia is called the sympathetic nervous system. Fight or flight is sympathetic nervous system. But which part of the autonomic nervous system is wine and dine, rest and digest, feed and breed? That is parasympathetic. Parasympathetic. And which part of the autonomic nervous system does the vagus nerve, which is cranial nerve 10, control? Parasympathetic. Parasympathetic. All right. Wine and dine, rest and digest, feed and breed, all parasympathetic. All right, the meninges. What is the outer layer of the meninges called? Hopefully you have dura mater. Durable, tough outer layer. And it will eventually split because it's a two-ply layer and form the dural sinuses that drain blood out of the brain, like veins would. What is the middle layer of the meninges called? The middle layer is the arachnoid mater, the spider mother. Spider mother, mater meaning mother. And again, mother, because all of this encases the brain and spinal cord as if they're in a womb, and the mother is symbolizing the womb. So the womb, mother, mater. Tough mother, outer layer, spider mother, middle layer, but the inner soft meningeal layer is called pia mater. Pia mater is the innermost layer. It literally means the soft mother, the soft part of the womb. What is the watery substance that we find bathing the brain and spinal cord? Cerebrospinal fluid, or CSF for short. And where can I find that? Which layer of the meninges? Not the dural mater, not the pia mater, but if you take that arachnoid mater in that space between the arachnoid and the pia, what's called the subarachnoid space, that is cerebrospinal fluid. All right, and again, those 10 pathologies, watch more of the videos to reinforce those 10, and I think you'll do just fine. All right, if there are any questions with the study guide, please let me know. Now, that means we can look at the cranial nerves. Thought I had that open. I guess I did not. Did I not? Yes, I did have it open. Okay, the cranial nerves, and we see the olfactory nerve, the optic nerve, the oculomotor nerve, and it's only spelled 1C. This is an old quiz. I didn't correct its spelling. Trochlear nerve, trigeminal nerve, abducens nerve, facial nerve, auditory nerve, glossopharyngeal nerve, vagus nerve, spinal accessory nerve, and hypoglossal nerve. And I'm even going to have it on the test like this with the cranial nerve and its number. You're going to have to match it up to what it does. All right. If olfaction is smell, we're simply looking for the sense of smell to match it up. You should have E. If optic is the sense of sight, then that means that that nerve is going to allow us to get vision to the brain. We should find sense of sight, which is K. Oculomotor is the eye mover. So this is going to the majority of the muscles moving the eye, not every muscle that moves the eye, but the majority of them. So I want to find moves the eye in most directions. Let's see which one says moves the eye in most directions. That says just down and in, so it can't be that one. That says moves the eyeball in most directions and constricts the pupil. That's the winner. F for oculomotor. Trochlear nerve is the pulley nerve, which makes the eyeball go up to the pulley, which causes you to look down and in. So down and in, moving the eyeball down and in, because that is the nerve that goes to the superior oblique muscle that moves the eyeball down and in. So you should have C for trochlear nerve. Trigeminal is the triplet nerve, allowing you in 3 branches to feel your face and chew. Feel your face, not facial expression, but the triplet nerve allows facial sensation. So when you see expression, do not pick expression for trigeminal. Pick sensation. So look at B, moves the jaw and relays sensation from the face. That is the triplet nerve. Abducens means abducting nerve because it goes to the muscle that abducts the eye, which makes the eyeball turn outward. So it's moving the eyeball outward, away from the nose. The muscle's called lateral rectus. We want to pick I for abducens. The facial nerve should be called the facial expression nerve because it does facial expression and taste. Not sensation, but expression and taste. H for 7. The auditory nerve is for hearing. So we just want to find hearing, go down to hearing, sense of sound and hearing. Where do we see sense of sound? Not A, not B, not C, not D, not E. Where is the sense of sound? All the way down at the letter J, the sense of hearing. That is what the auditory nerve does. Even if it says vestibulocochlear, once you see cochlea, you know it's for hearing because the cochlea is what we hear with. The glossopharyngeal nerve is the tongue throat nerve. And what do we do with our tongue? We taste and swallow. So find swallowing. Let's see. Swallowing, swallowing, swallowing. There it is. Tasting and swallowing, right? Swallowing and tasting, J. The vagus nerve is wandering all over the body to do parasympathetic stuff, which is slowing your heart rate, wine and dine, feed and breathe, rest and digest. And so let's go to slows the heart rate. It only says heart rate as far as I remember on the quiz here. Not innervates muscle, no. Move the other. So there it is, slows heart and breathing. That's a nice thing that the vagus nerve does, I promise you. Then the spinal accessory, I wish it was the cervical plexus accessory because it's there to help you move the muscles of your neck, innervating the muscles of your neck. A for number 11, spinal accessory. And hypoglossal means below the tongue, no taste buds there. So that's movement of the tongue, moving your tongue, letter G. E, K, F, C, B, I, H, L, J, D, A, G. Okay? That is your cranial nerve quiz answering. Hopefully you found that relatively easy. Now, the next thing that I gave you was a spinal nerve quiz, which I will open here. Spinal nerve quiz is, there it is, nervous system quiz. And you should have this picture now, okay? So The deep peroneal nerve, also called the deep fibular nerve, is the one that goes to the front of the leg, anterior R. And if it's going to the front, then it innervates the muscles of the front of the leg, including tibialis anterior and the extensor digitorum longus, extensor hallucis longus. The median nerve, the most important nerve of the upper limb, is important as it goes to the muscles of grip that allow us thumb side grip. We want the middle of the three in the forearm, which is letter O, letter O. And that's going to give us nice, strong, powerful grip because it's thumb side flexors like flexor carpi radialis and flexor pollicis longus and opponens pollicis. Absolutely. The lumbar plexus is the lower of the plexuses that letter E, it's the higher of the plexuses of the lumbosacral plexus that letter D is pointing to. D and E together form the lumbosacral plexus that innervates everything below the belly button, lower limb, perineum, you name it. If it's below the belly button, D and E are innervating it. Intercostal nerves run between the ribs. Notice the way that letter M is pointing to a nerve running between the ribs. It makes these nerves look like ribs themselves, but those are the nerves between them, and they innervate the skin and muscles of the correlating rib. The femoral nerve, the most important nerve of the entire lower extremity. Why? Because as it comes off the lumbar plexus and goes to the front of the thigh and then gives off that long saphenous branch, it innervates the quadriceps, rectus femoris and the vastus brothers. So we want letter Q. Letter O is here in the middle. Letter Q is the femoral nerve innervating the quadriceps. The cervical plexus of nerves is what's coming off of the upper portion of the neck to innervate the neck, the front of the neck, the muscles of the neck, the skin of the neck, the lower part of the skull and the skin of the collarbone area. That's what the cervical plexus does. It innervates the area of the head, face, and neck. As far as the cerebrum, letter J is pointing to that part of the cerebrum. That part of the brain is cerebrum. Again, cognitive and intellectual thought processes come from the cerebrum, right? We saw cerebellum for balancing against gravity, and we saw the brainstem for keeping you alive. The brachial plexus is the lower grouping coming out of the neck that letter B is pointing to. Follow those nerves. They end up innervating the upper extremity, the upper limb, the arm, the forearm, the hands, the fingers. Those nerves of the brachial plexus innervate the upper extremity. The sympathetic chain ganglia. Look at the way we've got this ganglia chain that letter N is pointing to along the side of the vertebral column to initiate fight or flight. The spinal nerve. Look at the way letter L comes right into a spinal nerve. These are actually numbers if we were to zoom in on that quiz. Like, watch, I'll zoom in. You can actually see, you can see numbers for segments. And we see one spinal nerve being labeled by letter L. If we were to follow that spinal nerve out, it's going to go to some muscle, it's going to go to some skin, it's going to go to a gland maybe, but it's as general as it gets. Spinal nerves go to skin, muscle, or glands to innervate them. The ulnar nerve is what's coming down the ulnar side, the pinky side of the forearm, not the back, but the front to go into the palm where you can grip using pinky side grip. So helping the median nerve with grip. Not nearly as important, but helping with grip on the ulnar side, like flexor carpi ulnaris and flexor digiti minimi. As far as the tibial nerve, that is the big nerve coming off sciatic that stays to the back, that stays posterior and ends up underneath the foot to become the plantar nerves. If it stays posterior, it will innervate tibialis posterior. It'll innervate gastrocnemius and soleus. As long as it's innervating a backside leg muscle, it is tibial nerve, which is posterior, not anterior. Tibial nerve does not innervate a single thing on the front side of the leg. So I'm going to put a frowny face if you tell me the tibial nerve innervates tibialis anterior. Frowny face. The spinal cord, letter K, right in the middle there. The central highway of information between the brain and body. And the sciatic nerve, the very large nerve coming off the sacral plexus that will become the three GR and H are pointing to. But it is sciatic nerve. It is letter F. And while it's still sciatic nerve, it innervates the hamstrings, which are biceps femoris and the semicisters. As far as the saphenous nerve, it is the long branch of the femoral nerve that I is pointing to innervate the skin, not muscle, but skin along this medial leg. The sacral plexus is the lower of the plexus that E is pointing to. Again, D and E together are the big lumbosacral plexus innervating the whole of the lower extremity. As far as the radial nerve, it is running down the thumb side bone of the forearm called the radius. It branches to the back of the forearm, the back of the arm. It is triceps and all the extensors, not grip. Extensors, letting go of grip. And lastly, the superficial peroneal nerve, which comes off of the common peroneal. It stays to the lateral side, innervating the lateral compartment. It is letter G. Lateral compartment muscles include superficial muscles like peroneus longus, peroneus brevis, also called fibularis longus and fibularis brevis. So hopefully you were able to match all those up, and you'll be able to do it again for me next Thursday when we have the test. All right, I'm going to stop the share here. Looks like we did it perfectly as far as being able to review and talk pathologies. Now, I am going to start new material tomorrow, but none of that information tomorrow will be on the test Thursday. This is the stop point. So everything up until this point that we started with the semester, you saw in the study guide, that you saw with these quizzes, will be on our test on Thursday. So anytime between 2 and 6, when I send later on this evening or tomorrow, I will send this link. I will also send information about the testing procedure Thursday, but it's anytime between 2 and 6. You can come and take the test in person. That will be part of the information. Good night, everybody. And we'll see you tomorrow at 3. Bye.